our congenital heart disease webinar series. Today, it's my pleasure to introduce our speaker, Dr. Douglas Overbey. Dr. Overbey is an assistant professor of surgery in the Division of Cardiovascular and Thoracic Surgery at Duke University, where he specializes in pediatric and congenital heart surgery. He is board certified in both general surgery and thoracic and cardiac surgery, and completed advanced fellowship training in pediatric cardiothoracic surgery at Duke University. His clinical practice spans the full spectrum of congenital heart disease, from neonatal and infant cardiac repair to complex reoperations and transplantation, and involves expertise in innovative areas such as robotic congenital cardiac surgery, as well as mechanical circulatory support and DCD heart transplantation. In addition to his clinical work, Dr. Overbey is actively involved in advancing the field through research focused on congenital cardiac surgery and transplantation, including pioneering efforts in partial heart transplantation and novel strategies to improve outcomes in children with complex heart disease. He also plays a key role in surgical education and training, serving as the mentor to the next generation of cardiothoracic surgeons. Today, he will be sharing his expertise on the repair of truncus arteriosus, an area that reflects both the technical complexity and innovation that define congenital heart surgery. Please join me in welcoming Dr. Overbey.
Excellent. Thank you, Ahmed. I appreciate the introduction and appreciate everyone inviting me to talk about truncus arteriosus. So I'm going to go through some of the diagnosis and then the management and some of the newer options we have for this particular lesion. As you mentioned, I do congenital heart surgery here at Duke, and truncus is a particular passion of mine because of what we've been working with lately with regards to partial heart transplant. And so I'll go over that kind of in the later parts of the talk as well. But just to go over the basics here, truncus arteriosus means common arterial trunk. So there's one trunk that comes off the heart, and then that supplies the systemic, pulmonary, and coronary circulations, all post this truncal valve. There's an overriding VSD with this, and then it can be associated with a VSD and then also with the truncal valve that can have varying degrees of insufficiency. And we'll go over that whenever we talk about the different avenues for repair. It's a failed development of the aorta pulmonary septum and the subpulmonary infundibulum when asked about the embryology. And the failure of septation then creates an infundibular VSD and then a single simulator valve and a single arterial trunk is the features of truncus. Clinical presentation, so early neonatal congenital heart failure is usually what we see. So if you keep in mind your list of cyanotic and non-cyanotic congenital heart diseases, this one is non-cyanotic, right? Because if anything, you have too much blood flow that's going to be going to the lungs because of the proximity of these vessels and the way they come straight off the aorta. So early in life, after birth, as the pulmonary vascular resistance goes down, then you're going to see this blood start draining off the aorta into the lungs. And then as that happens, you have what's overcirculation. Overcirculation, you can notice it by a variety of things, but in general, it leads to less output from the body because this output is instead over-circulating at the lungs. If you did a cath, you would see a QPQS of 2 or 5 to 1. You would see that the lungs are getting too much blood flow. Maybe they start to look congested. And then eventually, if it goes on long enough, you have symptoms of heart failure in the child, which will happen as the pulmonary vascular resistance continues to decrease after birth. On imaging, you might see cardiomegaly, pulmonary plethora. As I said, eventually the lungs get flooded with fluid, essentially, as they start to take on too much volume related to this lesion. It can be found on echo, and truncus anatomy, where the PA origins come off, you'll see this characteristic feature here, which is that overriding septum, and just one arterial trunk coming off of the heart. The important other things to look at are the valve function, and then where is the anatomy of the pulmonary arteries coming off of near this truncal valve. So to go into the pathophysiology a little bit more, it's an obligate mixing lesion, which means that because the blood only has one route out of the heart, that things have to mix, and that happens at the VSD level. Usually if there's an atrial level as well, you'll be able to see that shunt through the PFO and some mixing there. You'll see saturations because it's mixing, they can be low over time as you develop more and more over circulation. You'll see that maybe your pulmonary venous pressures or saturations start to go down over time, and then you can eventually see reversal and other downstream effects with the lungs as well. in general, you're going to see that the PVR as it goes down, you go into heart failure. That happens at a variable time based on when the PVR continues to go down after birth. There's abnormal truncal valve with regurgitation or stenosis. Those are the main things that you want to look at when you're interrogating the truncal valve. And that serves as the main determinant of outcomes because, for example, if you have a regurgitant truncal valve, severe regurgitation, that is the biggest predictor of a poor outcome after the surgery. And that's really what spawned other newer treatments for this, like partial heart transplant, that you'll see us talk about a little bit later. Three different types of systems here that are used to describe the anatomy that goes along with truncus arteriosus. So, Collett-Edwards is the number one, and we'll go through those different types in a minute. Van Prague is another categorization scheme, and then the Russell simplified scheme. All of these can be used in general to describe the truncal anatomy, and I'll get to the parts that are important of this. So, Collett-Edwards is on the top here, type 1, 2, 3, and 4. And just to go through these, type 1, you have one location of where the pulmonary arteries come together off of an MPA trunk that's coming off of the truncus itself. Type 2, you have two separate branch PAs coming off the back. And then if you move on to the other types, it just moves farther and farther away from them being the two PAs being either spread further on opposite sides like they are in 3 or coming from the descending aorta 4, which, there's some categorization of those as MAPCAs at that point, right? Major aorta pulmonary collaterals rather than coming off as a truncal type vessel. And then with Van Prague, you can also see how the distinguishing factors for where these pulmonary arteries come off. The important one is A4 down there. It gets you into the interrupted arch type of territory, which we'll cover in a minute. The reason that these matter for repair is that ultimately your goal is to get the pulmonary artery tree disconnected from this trunk and then put together back to the RV. As that happens, what you can see is that if they're close together, that's easy. So for like type 1, you can see how that kind of resembles a main pulmonary artery. You can disconnect it, you can reconnect it, and then you have nice orifices of the branch PAs. For type 2, or especially type 3 or 4, then those are farther apart. So that when the branch PAs are farther apart, you have to, in general, take a bigger strip of the vessel with it to be able to get those reconnected. And sometimes you have to get a little fancier with your repair techniques. So here's some pictures of kind of what the collet looks like. Is the most common classifications that we'll talk about. So again, from the front, you'll see this main pulmonary artery coming off with type 1 truncus. That's nice. That's favorable for repair to connect for your distal RV to PA conduit. Type 2, the PAs come off kind of opposite each other at almost 180 degree. And so in that instance, you have to really connect these two PAs with usually a strip of the main aorta that you're taking off. The important thing to distinguish there is that the coronaries are coming off as well, right? So the spacing of where the sinuses are of the truncal root and the coronary arteries and the pulmonary arteries, you have to be really cognizant of all of that because whenever you're trying to take the pulmonaries off, you obviously want to leave the coronaries down by the sinuses, and sometimes they can be closer than you would otherwise think. Associated lesions, so things that you're looking for whenever you're getting a full analysis and scan of a truncus. A VSD, of course, is a part of the picture, an obligate part of this picture. Anomalous coronary or single coronary is really an important feature they have to figure out for us before we're willing to repair this lesion. That's because you got to know what you're looking for. You got to know where the coronary arteries come off, and you got to be able to distinguish those from the PA, both on direct inspection, but it helps to have that ahead of time from your echocardiogram. And then interrupted arch, most commonly type B, but the interrupted arches are going to be another feature that you want to figure out. These kids are usually born with a duct, and so you want to be able to figure out where the other parts of that arch come off and if it's something you have to deal with at the same time that you're dealing with the truncal repair surgery. Another important distinction, because this will come up sometimes, is how is this different than tetralogy with pulmonary atresia? Well, the anterior malalignment of the ventricular septum, that's a feature of tetralogy, is a little different than this. Most importantly, how do the actual vessels come off of the heart itself, right? And so sometimes you can see these mixed up. If it's real narrow pulmonary atresia where the pulmonary arteries are coming together as one branch, so they're arterized normally, but they're not directly connected to the aorta, that's pulmonary atresia. And that'll have a ductus that'll connect it oftentimes, right? So once you get into MAPCA's territory or a TET PA with a duct, it can become a little bit difficult at first or fetally for them to figure out if this is truncus or not. So just something you have to be sure that you distinguish properly before you embark on a surgery. Truncus with interrupted arch. So look at that picture on the right. You can see how, if the interrupted arch is type B, where the subclavian is coming off of the ductal arch, then you'll have a different feature and a different repair technique than if it's the standard on the left, which is without an interrupted arch, right? Plus or minus the duct being there at all. And so you have to be sure and really look at that area and see where the arch is connecting, make sure that the arch adequacy is, in fact, what you need and expect. Otherwise, it does change your repair technique. Now, how you repair it can be done in a few different ways. With this particular lesion, if you're going in for repair a truncus with an interrupted arch, then the first thing you'd want to do is, after you get in and go on bypass, is occlude your branch pulmonary arteries and cool. Sometimes people do that with 2 cannulas if it's a ductal arch in addition to the arch that you have on the left for a truncus. So different considerations going into repair, but ultimately, they used to say that the interrupted arch added a lot of complexity to the operation, but in general, if you're a congenital heart surgeon and you're dealing with arch problems routinely, it doesn't really add mortality. It can add morbidity, but usually not mortality to your repair and operation. That's most dependent on how the truncal valve is behaving. There's classification schemes, for A and B with types 1, 2, and 3 from each category that can go into the really nuances and specifics of where is the interruption in the arch, right? So A always being after the left subclavian, B being before the left subclavian, in addition to what that can look like with type 1, 2, and 3 truncus. And so they're just orientations of how the branch pulmonary arteries come off. But here's some percentages that are up there as far as which one you see the most commonly. So on to the operation and the management of that, which is kind of the majority of this talk here that we're going to go through. So you go in and looking for a truncus, here's an example of what you'll see, right? So there's an atrial appendage, here's the ventricle, and then coming off of it is just one vessel, one tubular vessel coming off. The coronaries are over here, and then this goes off into a pulmonary artery back behind it in each direction. There's one here, there's going to be one behind it, and then this goes up into the aortic arch that goes up and around behind over here. Importantly, one of the things you want to look for whenever you get in is the coronary anatomy. So just like they were trying to find it for us on the echocardiogram ahead of time, you want to look for yourself personally. Why? Because you want to make sure that you have somewhere where you're going to put your RV to PA conduit ahead of time. So sometimes these conal branches can go across in various areas here, and you can see that as that occurs, maybe you have to choose a more specific location for where you want to open up this right ventricle to put your RV to PA conduit eventually. You want to identify your branch pulmonary arteries. A lot of times you can do those out close to the hilum of the lung. That allows you to control those once you go on bypass so that you don't just drain off, all of your bypass circulation. And then the other thing you want to notice is that where these coronaries insert behind the heart back here, assuming it's a normal coronary pattern, then you want to know exactly where that's going in and find the plane with which you will cut to get your pulmonary arteries off and keep the coronary arteries right where they belong back behind. And so there's some planning, once you get in and look at the front of a truncus, where you want to make these incisions, if you want to open up the whole root, or if you just want to take off this as a cuff and then patch it. It kind of depends on what you're doing, right? If you need to repair the truncal valve, then you're going to transect this. If you don't need to repair the truncal valve because it's working well, then in general, you just want to get your pulmonary arteries off with however much tissue you need to be able to connect them to the RV, and then you want to patch that part of the aorta. So that's where we're starting with here. The surgical goals, if you want to make it into an itemized thing, you have to separate the pulmonary and the systemic circulation. That's a big feature of this. You want to close the VSD with an LV to aorta shunt. You want to reconstruct the right ventricular outflow because you have to connect the RV to the PAs. Remember, these kids have 2 ventricles, right? So your goal is that you get to a nice biventricular circulation, which you can do if it's just truncus. And so you want to be able to close the VSD in a way that leaves a chamber that can be conducive to an RV to PA outflow tract. And then you want to make sure that it's unobstructed where your LV goes to your PA. And usually just due to the alignment of the outflow tract itself, that's not a problem. But always things you have to consider, right? That you try to get your baffle in a way where the LV flows freely out to the aorta that's left, and then you can connect what's left of the RV into the pulmonary arteries. So these are the different steps. Rastelli baffle is one of the versions you can call this VSD patch essentially, but you're going to be closing off the right side of the septum up to the annulus of the truncal valve. And then that's going to close off this chamber, which then you add your RV to PA conduit. So here's an example, if you just had a type 1 truncus where there's a main PA segment, here's an example of what it can look like, right? You start out by going on bypass. You want to do that distally up in the arch. If you need to reconnect an interrupted aortic arch, you can do that in a variety of ways. And that's kind of surgeon dependent. Some people do circulatory arrest. We put in 3-region cannulas, including a descending, and then we keep blood flowing everywhere the entire time, including the heart beating here while we're doing the arch reconstruction. Typically, it just depends on where the ductal arch is and how big it is, but that's our general approach to it. So you would do that first in that case. Reconstruct your interrupted aortic arch if that's a problem. If not, then you just tie out the ductus, and then you're left with this right here. All your other work is on this side of the clamp, right? So you can, once you cross clamp and arrest the heart, then you have arterial circulation flowing here, and you're dealing with everything inside the heart. You always want to bicavally cannulate whenever you're dealing with right side of the heart and you're opening that up, which here you certainly are, right? To be able to get into the RV, to do the RV to PA conduit. So you can see if it could be this simple, right? Unfortunately, most of them are nowhere near this simple, but it could be this simple for type 1 truncus. You take off a chunk from here, you sew on a patch, you connect this to this after closing your VSD, and you're done, right? Usually there's other things to do, but that's kind of as simplified as it could possibly go. So to go through the specifics of that repair technique, again, bicable cannulation, snare the PAs. That's sometimes a question that shows up. And immediately you have to snare the PAs in the case of truncus because otherwise all your bypass fluid will just drain off, right? And you'll have low pressure, or you'll flood the lungs, even worse. Mild hypothermia and then antegrade cardioplegic arrest. The intracardiac steps here, once you divide the truncal vessel or remove the PAs, you have to patch the aorta back together. That can be simple or hard depending on the anatomy and how much of the aorta you have to take with your branch PAs to be able to get them together, right? So sometimes with truncus, as we showed, if it's type 3, let's say, the branch PAs are really far apart. Well, your options are either you take a strip of aorta, which is native tissue with that, or you take each PA off individually and you reconstruct the PA cariner or flow divider or whatever you want to call it, to where then you can reconnect the distal conduit to it. Sometimes those branch PAs are small and you can have downstream stenosis of that area. And so you want to be sure that you're doing with it, if you can, with native tissue. And that's what is involved in taking off the aorta from the pulmonary arteries. Once you close off the ASD in general, like I said, you're septating these children, right? So you close the VSD with a patch on the inside. It can be a curved patch, it can be a flat patch. It all depends on the anatomy. But then you should be able to close off the ASD at the end of it. Sometimes we leave a tiny one just to be able to monitor post-operatively if there's a chance of RV failure. Anytime you're making a right side of ventriculotomy in a neonate, the RV can suffer afterwards. And so sometimes it helps to just have that monitoring post-op, but that's all surgeon and ICU dependent. Then you de-air and come off bypass, right? That's the conclusion of it once you put your conduit on. So here's a picture of kind of what the VSD can look like. Your RV incision is remote from the truncus itself if you're not doing a root replacement of any sort. And so, like I said, you're inspecting for coronaries, you're opening the right ventricle, you're coring out, similar to like a tetralogy with a conduit, right? You're trying to make sure that you have an even outflow and there's no muscle bundles obstructing. And then once you close the VSD patch here, which on the inside, you'll see where the RV used to be pumping into the aorta through this lesion here. Once this is closed off, then the RV is obviously septated away. And so then it just comes out in front of you here through this conduit, which you can place over in the left-sided chest to connect over to here. But that's as simple as closing the VSD can get. The RV to PA conduit, there's different types, right? We used to use bovine jugular, which was called Contegra. Those have a slightly higher infection risk, so maybe we use homografts now here. Those can be cryopreserved. Those can be living. If you're at a place that doesn't have access to homografts, like sometimes some overseas countries have issues with procuring those, then you can do native tissue reconstructions here, where you use native tissue from the back wall of this, you just sew it down to here, and use native tissue for a patch on the front. You have to and fro flow. The initial post-operative recovery may be a little bit more difficult, but perhaps it could grow more over time, which is always a consideration if you're not somewhere that has a ready supply of conduits and being able to do replacements. That goes into some deeper decision making in terms of valved or non-valved RV to PA conduits. But the point is you just reconnect your right ventricle to your pulmonary artery. Truncal valve repair can be a big feature of this, and for a TMSA talk, this is a little bit probably beyond what we should be spending a lot of time going in depth on. But I at least wanted to show you guys what kind of we can do and what options we have because it's really cool for these truncal valve repairs. The truncal valve itself, if it could be stenotic, right, which means it has a gradient, it's too tight. It can be regurgitant, which means it leaks because the kind of crown-shaped annulus doesn't come together. So in that case, you have to deal with either one of the two. They can have a variety of different leaflet numbers. So this one I'm showing here has four. It's called a quadricuspid valve. A normal adult semilunar valve has three, right? It's a tricuspid valve. But we can see anything with truncus. These can be bicuspid valves, quadricuspid. There's some described as having five cusp. There's different ways to repair them depending on what that looks like. But the point is that you want to try to reconstruct a valve that can open all the way to alleviate stenosis and that can close properly to help with regurgitation. And so if that's a quadricuspid valve, then sometimes you have to do an annular plication here, which is where you're pulling in on each side a little bit to try to make sure this coaptation zone in the center is together closer, that you have a surface where these can come together like this with more dimension touching itself. And so that's one route of repairing these here, is crimping the truncal wall, reducing the diameter of that. That brings everything in together, similar to any annuloplasty we do, in a way that the leaflets that are there can touch each other. There's all sorts of different ones. There's cusp approximation here. There's suture annuloplasty. Sometimes the leaflets are thick and you have to do shaving and thinning of the leaflets. You can resect an entire cusp here and then sew this back together. And so there's a lot of different options here. A common one that you'll see brought up is called tricuspidization, which is where maybe you have four, one, two, three, four different cusps that are there, but perhaps these two look like they want to become one. Well, that's a good candidate for becoming a tricuspidization procedure. So as you can see here, you can remove the cusp, you could take out the frenulum in between and then turn that into one cusp. It all just depends on what you're dealing with. And so again, this is kind of, I think, beyond the scope of what we're talking about today, but I just wanted to at least mention these because there are so many options for truncal valve repair. And if you get a good result, that can be a lifetime of benefit for the child. You can't always get a good lifetime result, unfortunately. And that's where the concept of partial heart transplant came up, okay? So if you have a small child with a poorly functioning valve, so remember, truncus is unique because you have one semilunar valve, right? As opposed to most other congenital heart lesions, maybe the other one's there, but it's small. Maybe it's there, but it doesn't work well. In this case, you only have one valve coming out in the case of truncus. And if that valve doesn't work, you have zero semilunar valves. And so it's not like you can do a Ross operation and take the pulmonary valve. It's not there. So instead, you have to replace both semilunar valves with new ones. And that's where we came up with the concept of a top half transplant or a partial heart transplant or a double living root replacement, any of those. Because of these issues here, right? Most replacement options, if you were talking about 5 years ago before we started doing partial heart transplants in 2021, your only option for these children was to try to repair the valve or to do a cryopreserved living root replacement. Those are the only choices because the smallest mechanical valve we have is 15 millimeters. It has an 18 millimeter annulus. Usually that's too big to cram into a neonatal setup here, even though, in general, the truncal root is big. It's not 18 millimeters big in a neonate. So that option is not typically appropriate for a truncus baby. Then you have the cryopreserved roots. The problem is root replacement from a cryopreserved homograft is going to fail, and it's going to fail at a fast rate in neonates, even faster than larger kids or adults. So maybe you do a big repair, you replace their root, and then 2 months later they have truncal insufficiency again, right? Bad, bad problem. And so here are the issues that led to eventually partial heart being developed. Replacement options aren't good, valves will not grow with the child, and the homograft fail rapidly. Here's an example of homograft valves failing rapidly, right? So truncal valve replacement neonates and infants, whenever you replace it early on, there's an early mortality rate of 50%, and then a late mortality rate of 15% per year and a reintervention of 20% per year afterwards. So awful, just abysmal results whenever we were using cryopreserved homografts in the aortic position for truncal valve replacement.
It was the only option at the time, but and 4 years ago that was still true. It was the only option, but it's a horrible option. I mean, look at this mortality rate of 50%. So that's where partial heart came about. That's why we kind of tried to push this forward and develop this, because you can use simular roots plus immunosuppression, and then those valves will continue to grow, right? It's based on the concept of a heart transplant. If you do it in a tiny kid, the heart valves continue to grow, they don't reject, and over time, they engraft in a way that's favorable. And so that's where the concept kind of was developed, is that we need two roots, two simular valves. Both have to be replaced, so let's use them from a living heart that can grow, and then you won't have as bad of issues as if you try to use cryopreserved ones. So, we did this 4 years ago. Here's an example of like a 3D model that you can make, and sometimes it's helpful for any truncus case if things seem off to you. If you're very experienced and you've seen a bunch of these, then it's no problem at all. But if you're having any trouble figuring out where's a coronary, where are the PA branches coming from, where's the ductus, how's the interrupted arch divided, all these things I think are important features of being able to figure out how to do the repair and plan it accordingly, as especially an early career congenital heart surgeon. So these models are super cool, and there's actually a 5 up here in my desk for different cases that I'm doing. I mean, all these things, like, you can make these easily, and hopefully you guys see these for different hospitals that you're at. It's like a regular part of my day. Probably 3 or 4 times a week, I have a 3D model of some sort similar to this that you can plan repairs with. So, like I said, hopefully you see these, and if not, try to look into what kind of imaging can be done at your institution, because like all the time you spend pre-gaming and planning ahead of time is that much less time you have on bypass and with a cross clamp on, right? Which leads to a better outcome for surgery. So anyway, we did that here with this is just a truncus case where we did that. It allows you to plan the patch. We were trying to figure out, if we replace the root, how should we close the VSD? Should we use the part of one of the roots or the mitral valve, or different options for that? So that's why we did it. Turns out that it's actually easier to replace the roots one at a time because it gives you a better look at the VSD. But you can see here from this, once you take off the root, and by that I mean you're actually cutting the entire truncal valve out, then you seed in root number 1, which is down here in the bottom left. That goes down into the position where your truncal valve used to be once the truncal valve was cut out. So obviously it couldn't be repaired, right? Which is the reasoning behind needing to do this. Then you seat this root down here. You apply the coronaries back to it, just like a Bentall root replacement. This valve goes in, it works great. Then you use your other valve to connect the RV to PA conduit, which is up here. That's the concept of a double root replacement. I have a video of one here I want to show you because it's really cool to see. But the key is that the obviously you have to do the truncus repair as a part of this. That's easier to do whenever you're adding this entire sinotubular junction from replacing the root, right? So you put in a new root down here in the bottom. You can use as much tissue as you have from the new aorta to reconstruct this whole area. So you're not doing a bunch of patches back behind the aortic arch, which sometimes you are in the case of truncus with doing a native repair. But anyway, here's then the distal where it's going to connect. And once you put in the new root, which is sewn 4 different places, right? A proximal down here, including your VSD patch, in addition to the annulus of the left ventricular outflow tract, then a distal, which is your aorta up here, and then each coronary. All 4 of those things are sewn in, and then you have yourself a new root connected up. So, the first kit we did this on was 2.5 kilos, severe truncal valve insufficiency. Here's an echo of truncus. I haven't shown you these yet. So just keep in mind, this is the left ventricle, the right ventricle, and then see how things are connected here. This insufficiency going backwards is what you're really looking at as far as saying, wow, that's a bad truncal valve. All the blood flow away from the direction it's supposed to be going. That's a problem. Also keep in mind that's a problem if the kid like crashes on ECMO, right? Because then you're just going to recirculate all this blood and have a terrible time. So all different considerations of these kids that are in a bad spot when they're born, which is severe truncal insufficiency. So here's the direction of how things go as far as sewing back in the double root replacement. We went through some of this. Here's the video that I'll show you. So here we are procuring, this is on the back table, just a regular heart homograft, right? So you have to find a way to get the upper half of the heart off of the ventricles and the rest of it in a safe way to be able to sew these in. They do this for you if it's a cryopreserved root, but for us, we have to do it ourselves, right? So you have the heart graft sitting there. You're tying off the coronaries because the root that is going into the systemic position is going to be the aortic root. right? That's going to become the truncal root. And so here we are in the left atrium now, opening up this area, and that's going to show you where the mitral valve is, and the aortomitral curtain, and everything that's related to the aortic valve. So there they are. Now you have two roots. The RV to PA we're used to getting, because we get that every time for like a Ross operation. So, but anyway, there's two roots next to each other. Those are going to become the top half transplant. Here's a truncus child that we are dealing with. So you can see here is the antegrade needle on top there. That's cardioplegia. And then we're cutting just below that and opening up the entire, we're transecting the aorta so we can get a really good look at this truncal root. We knew it was really leaky because of that echo I just showed you. And so, the decision is it repairable or not? Here's the truncus. These two PAs are coming off together. So I think this was a type 1 or a really close type 2. It looks like a type 1. Excising the native truncal valve here is because it's not repairable. So once we deem it not repairable, you see how those leaflets are thick and dysplastic and nasty. So those come out. Coronaries are now getting isolated as well. So coronary buttons, the ostia, the left main and the right main are coming off. Those are pulled away to where now we can work on the truncal root. So if you're replacing both valves here, if you're replacing the entire truncal root and you don't have crossing coronaries, it makes this really easy because we just extend it the same incision down to the front of the heart and you're kind of splayed wide open, similar to like you do with like let's say an Aikido or a root translocation procedure. Now this first root is being dropped down into the heart. And so that's root number 1, and we're going to sew that to the back wall of the LVOT along the back, and then in the front, it's going to wind up connecting to the VSD. So that is the root replacement of where the truncal valve used to be. Once that area is all connected up there, then you're left with a kind of a gaping hole in the front, but the VSD is closed because you sewed down into the VSD. So now the RV is splayed open, and we're going to be ready to connect that in a second. We got to get these buttons on. So you can punch out holes in the native sinuses. You can do trapdoors. There's a bunch of different ways to do this. Whatever your preference is, you can sew this up. So now the coronary buttons go into the root down by the sinuses. And then, like I said, you have plenty of tissue distally where you can connect and do a distal aortic anastomosis now and avoid some other patching material. So again, all this tissue should be alive, right? Because it was freshly procured and you're immunosuppressing it afterwards. Similar to if you do a heart transplant, all the vessels are alive, and that means they'll continue to grow over time. That means that they'll engraft and grow into the body. They'll get replaced partially by cells from the recipient. And that's what we've seen, over time is that it does continue to engraft and grow. And so that's really been a remarkable change and improvement for these children. So here's the RV to PA conduit going in. And so this, you're connecting kind of muscle to muscle where you had made your incision where everything's wide open now. And you'd already done the distal anastomosis. So now this part of the heart is going to allow the right ventricle to connect up to the lungs, which is going to allow both sides to pump in their anticipated proper locations. So that's a double root replacement. One of the biggest operations we do, to be honest, on children, because there's so much that goes into it, right? So there's a lot of press, with partial heart. I do think truncus is like the perfect indication for it. There's other things that we do it for now, but it's in Gray's Anatomy. If you haven't seen that episode, you should take a look at it. It's pretty good. It's the same one that Gray, I think, quit the show. So it's a cool episode regardless. But they did have real parts of the video that we did for the very first one of these in that episode, which is kind of neat. Partial heart transplants overall, we can do a ton of other things with it. That's not the main feature of this talk, but you can see how, truncus is a common one that we do this for, critical AS, other things, and you can see how the technique could be applied elsewhere. But truncus is just a fantastic reason, either at the initial operation, or let's say you can get them through by repairing the truncal valve and they come back at age 10 here and they have a problem, right? Which happens commonly because let's say you have moderate truncal regurgitation after repairing it. Well, that'll get worse over time, right? Because everything's going to grow and dilate. And so if that continues to get worse, and again, you can't repair it, they already have a conduit in one position. And so now you can do a double root replacement, which is something that we, commonly do here now as one of the options for truncus. So let's just briefly look at the outcomes. I mean, again, it's dependent on the truncal valve function. If you have truncus with severe regurgitation that cannot be repaired and you have to replace it, and you don't use a partial heart transplant, the outcomes are horrible, 50% mortality. Over time, are they going to continue to grow if you do a partial heart transplant? Yes. So that's good news for longer term growth. And your initial operative mortality is a whole lot lower. It's never zero, but it's probably closer to 20% than 50%. So in summary here for truncus, it's a mixing lesion, but eventually manifests as pulmonary overcirculation. One other thing I was going to mention with that is that you might see in the textbooks pulmonary artery banding come up for these. That's an option, right? It's particularly if you have some reason, because it's an overcirculation lesion, you have the option of banding PAs. Most textbooks are going to tell you that that was historic and we don't do that anymore. In general, that's true. If they have some other contraindication or comorbid feature where you don't want to repair them, you can still do that. And the other thing that's showing up now is internal flow restrictors or catheter-based bands that are a decent option if there's some other reason you don't want to take these neonates for surgery. A head bleed, a concomitant like GI lesion or something that needs to be dealt with, tiny birth weight, athymia, those kind of things should all be considered. But in general, you whisk these kids off to the operating room and repair them shortly after they're born, because otherwise they will have worse and worse pulmonary overcirculation as their main feature of presentation. And that leads to clinical deterioration after birth. If you don't repair them, they will die. Surgery converts it into a pretty good serial circulation, especially if you have a good valve there. And then the partial heart era gives us another option for ones that don't have a good valve. So that's a consideration for that particular population. Outcomes are all driven ultimately by timing of operative intervention, how sick they are going into the OR versus, are they transferred to you? Were they born? Is it a known fetal? All those things kind of compound the equation. But the big one you're looking at is valve function. That's going to be the ultimate determinant of how well these children do afterwards. So that's all I have prepared. I think we have another, looks like 15 minutes or so for questions. If anyone has questions.
Yeah, Dr. Overbey, I was just wondering if you could talk a little bit more about the long-term outcomes of this. So say, we catch this early, do the procedure, it turns out great. What is that looking like in 10 years, 20 years down the line?
That's a great question. Yeah. So, the mortality, as I mentioned, the mortality is driven by the truncal regurgitation. In general, they don't have severe regurgitation, obviously, right? In general, we can leave the truncal valve alone. That's the case in about 2/3 of them. You don't have to do anything to the truncal valve because it works well. So then, as the children continue to grow, I always kind of divide things up into what is a feature of the anatomy versus what is a feature of the physiology. Separate those two things out, right? So if you're able to do a repair that septates the heart and you have two circulations, right? Which unfortunately you can't all the time, but in this particular lesion, generally you can. If you have two circulations, physiologically, the other organs of the body will not suffer from that, right? So you don't see a lot of the downstream problems that you see with other lesions where you can't get to a two ventricle circulation out of the gates. Now, in this case, there are residual anatomic features that you may have to deal with later on. So if you have a conduit placed at birth, and it's not a living conduit, we don't really have the long-term 10-year, 20-year outcomes for those, right? But if it's a standard run-of-the-mill decellularized, cryopreserved homograft, usually what you're putting in at this size of a child is something in the 9, 10, 11 millimeter range, right? And that's usually a Z-score of 0 to +2.5 for a kid that's 3, 4 kilos, right? So if you put in a 10 or 11 millimeter conduit, more often than not, that will not be the conduit that gets them to adulthood. So then they will need that RV to PA conduit replaced at a subsequent surgery. Unfortunately, the timing of how cryopreserved homografts fail is extremely variable, which is why we like partial heart transplant, because it turns that into less variable. I've seen kids with 14 millimeter homografts that only last 2 years. I've seen kids with 11 millimeter homografts that have last till age 10. So it just depends, right? So I can't tell you, I never can tell families, okay, I repaired your truncus, we used a cryopreserved homograft, your next surgery will be somewhere between the age of 2 to 5. Okay, you can't say that. That's probably what's going to happen, is that somewhere between 2 to 5, you'll be able to upsize them from a conduit that's 11 millimeters to one that's 20, and then that'll get them to adulthood. But you just can't do that because they don't fail that predictably, unfortunately. The averages sure pan out like that. But that's the next surgery they'll need.
they shouldn't need other surgeries. If their truncal valve was good and continues to function well, then you don't have to address it. Coronary ischemia shouldn't be a common feature of these. Pulmonary artery stenosis distally can occur. The first step for that's always the cath lab. It's not reoperating on something, right? And so a lot of times what you'll see is some branch PAs where the ostia is smaller because of the way they were kind of stenotic where they took off from the aorta. So then downstream, they can get a catheterization procedure to try to balloon dilate those. You can stent those. You can repair them if they need a conduit change. Those are all kind of the sequence of options. In general, though, you'll notice what I'm talking about is right-sided problems. Right side of the heart out to the PAs. Those are so much easier to deal with than left-sided problems, right? Which is maybe my truncal valve was moderately regurgitant, and now we're watching it. It's moderate to severe, and then they wind up needing that valve replaced, right? That's the more severe, more kind of pressing issue that is complex to deal with.
Great. Thank you so much. Super
Yep.
interesting.
Hey, Dr. Overby. Thank you very much for the talk. I have a question for you. Um, I'm curious about coming up with like a procedure like the partial heart transplant, and you mentioned a little bit about the immunosuppression. So how do you guys determine how much immunosuppression you have to give a patient when they undergo like a new procedure like this? And my second question is about like from a regulatory standpoint, do you guys have to clear anything with the FDA when you want to do a new procedure like a partial heart transplant or
Yeah.
yeah.
Those are both great questions. I mean, it's anytime you're kind of forging unknown territories of new operations, I think you have to consider all those things, right? And so some of it is based in science, and some of it's based in clinical acumen. So for your first question, immunosuppression, that's something that we go back and forth with a lot. And so, I think the safest thing you could say would just be to treat it like a heart transplant, right? That's kind of the most conservative approach. And some centers do that. If you really thought that these valves behave the same as a heart transplant and you had all the same risk, I think that would make sense. I don't really feel that way. For example, whenever we stop immunosuppression or whenever the heart rejects, the valve doesn't fail. We hardly ever see the valves fail in like a rejected heart transplant, right? It's the myocardium, it's the pumping chamber that fails. And so usually the valves are a-okay. They've grown fine and those aren't rejecting in a way that like causes stenosis or regurgitation. So is it worth keeping these kids on full dose immunosuppression for their entire life? Well, there's a lot of risk with that, right? And so I don't think that's a favorable trade-off to make. And if you certainly look at kidney transplants, cornea transplants, other things where maybe endovascularly is how the blood supply to the tissue, not the organ. It's not an organ, right? It's a tissue, which gets to your second question. But how that tissue is going to behave and how it gets its nutrients and how it engrafts, that's something that we are kind of figuring out in the laboratory. So we're doing electron microscopy on these studies down the road. We do them in pigs, right? So we do pig surgeries with a partial heart transplant. Pigs grow a lot faster than humans, and so we see how it grows. We see how it behaves. We see what cells try to take over inside the graft. Are they usable cells? Are they immune infiltrate? So all those things are at play here, right? So part of it's the science of what you already know about it. Part of it's the clinical presentation of, what would it be like being on full dose immunosuppression for your entire life? Well, that's a big ask for these kids. They get sick a lot. That's a big ask as opposed to saying, okay, well, we need the valves to engraft for the first year. That's the important time frame. And then we can drop it down, similar to how you can drop down kidney transplants, right? I mean, so you just have to kind of consider all the different relativity of the tissues that you have. And that's where things ultimately wound up with us saying after a year in the systemic position, we go to half dose tacro, goal 4 to 8, versus in the RV to PA position, it's less important and we have endovascular rescue options. So we drop down earlier after 30 days to less immunosuppression in that population. But if you were answering this to other IRBs or something, I think it has to be a patient-centered discussion. And I think it has to be, you have to consider what the downstream risks are if the valve were to fail, right? So all those things were at play with us deciding how to handle our immunosuppression regimen. But it is done differently at all different centers, which means there's not a good consensus yet to tell you. As far as the FDA, yeah, I mean, you have to go through all that stuff when you're doing a new operation, right? You have to make sure that your local IRB is up for it, that your hospital is behind it. You have to figure out which parts fit within standard of care. It's pretty easy whenever the standard of care has a 50% mortality rate, right? That makes it pretty simple to get that through IRBs because the standard is so bad that almost anything will be better, right? So that made it easy as a push for truncal valve replacement. But you have to hit all the regulatory things. And so, we went through UNOS to try to figure out, do they want to handle this and treat it as an organ? No, they said no. The FDA initially said no, and they came back, a couple of years later and said, okay, yes, actually, we should regulate this as a tissue. So now to be able to do these, you have to have FDA approval for tissue monitoring, chain of custody, all the testing involved to make sure that what you're implanting in somebody else isn't like ridden with Zika virus or something else transmissible, right? So all those are important regulatory checkpoints that you have to make sure that you do appropriately. Now, whenever we started this, we were kind of blazing new paths, but now there's been about 50 of these done in the country, or 60 by now even, and across 10 plus institutions, and even across the world, there's a couple more places that have done them. So there starts to be kind of the development of some guidelines that are associated with that. And we certainly try to help to make sure that everyone that wants to be able to do these, because it is treating a bad problem, I want more people to do it, right? And so as more people do it, you want to make sure that they have all the knowledge and skills that they need to be able to succeed with it. And so that's where we're trying to put that framework together, but also then keep an eye on what we've done with a registry to where let's say these turn out to be a terrible idea, or maybe they turn out to where you do need more immunosuppression longer term. Well, we want to know that, right? And the only way to do that is to track what you're doing long term.
Thank you very much, Dr. Overbey.
Yep.
Hi, Dr. Overbey. I did have a quick question about what management looks like for patients as they wait for this partial heart transplant. I do research on like the adult side, and we see like bridge transplantation through devices like LVAD. So is there any like possibility for like device management of that overload for the pulmonary artery side as patients wait?
That's a great question. And it's changed recently, because we have this growing experience with the internal flow restrictors. So, it used to be that you had to put on branch PA bands. There's no main PA to put a PA band on. So you have to put on branch PA bands for these. So that's a little different than a normal PA band, but it can work. It can work great, right? Because let's say you calibrate the internal size of each PA, branch PA, to you time over a 3 millimeter dilator, and maybe it's 2 millimeters on the inside. That's fine. That restricts flow. It at least limits, it palliates your overcirculation for a while. But the clock is still ticking, right? The clock is ticking until, either that's going to be too little blood flow or the PVR is going to keep dropping. And maybe it's for a while, it's too much blood flow still. Either way, you have unrepaired congenital heart disease, right? So the question is, what are you waiting for at that point to repair? In general, we still do these as a neonate. There's no reason that we say, okay, at 30 days, it suddenly becomes easier than at day 3 of life. I don't think that's true. Sizes don't change that much. Usually they're not feeding and gaining weight in a meaningful way over that short of a period. So, but sometimes there are things that make you wait, right? If you can't put them on bypass dose heparin, if you can't, if they have other intestinal atresias, there's comorbid things that happen a lot with truncus. And so if you can't operate on them or you have to wait to do something else, internal flow restrictors, catheter-based placement of those is a good way to do it. Now, the difference between those and some other lesions that we have is that those are connected to the root, to the truncal root, right? Almost directly. So you have to make sure you have the anatomy that your catheterization team thinks is appropriate for placement into the branch PAs. Because if either of those somehow eject, they'll go out into the systemic circulation in the brain, right? And even when you're operating on them and you're taking those out, you have to be careful that you don't accidentally squeeze them out into the main truncal root. So all considerations, but we certainly do that. We put in IFRs on these if they're real tiny birth weight, if they have intestinal atresias, if they have athymia, if they have something that makes us say, ooh, we got to wait, head bleed, right? All those give us an option to where we can bridge to being able to do the right surgery. Now, an interesting question comes up with severe regurgitation, right? Because they don't have a good bailout of mechanical circulatory support. Like I mentioned, you don't want to put severe AI on ECMO, or the heart will usually stop working right in front of you. And so what you have to worry about in that case is, okay, well, how bad is the regurgitation, and is there any other intervening option that we have, right? So would you do IFRs then while you're waiting for a living root to become available? What size roots do you need? What blood type? Does blood type matter? How fast can you get them? Are you close to being able to get those in? Those are all things that we consider. So for this first kid, we actually wound up waiting about 3 weeks before we were able to repair it to get roots. The system's set up a little better now nationally, where we can get roots across the country. And so in general, hopefully that's not a limiting factor someday, the availability of roots and being able to get them from California or wherever you are. And so we hope that, that doesn't limit us as much in the future as it does now, but it's all a consideration. What's another one? Well, Xeno, right? I mean, so could you use porcine roots in these kids if you needed a double root immediately, and then that could bridge you to being able to wait and get bigger human roots? Maybe so.
Amazing. Thank you so much.
Mm-hmm.
Well, Dr. Overbey, thank you so much for a wonderful evening and educational webinar. TSMA is extremely appreciative of your time. This was tremendous. I'm going to just end by kind of asking a general question. A lot of people on this Zoom are, they're aspiring to become pediatric heart surgeons. Do you have any general advice for medical students who are looking to become pediatric heart surgeons?
Yeah, of course. I get that question a lot, and I think it's important, at every step along the way, you have to try to be the best at whatever you're doing because, first off, you may not want to be a pediatric heart surgeon. You may think you want that, but then it turns out you actually want to be a pediatric cardiologist. Maybe you want to be a pediatric general surgeon. Keep all the doors open. That's my advice to everyone, right? Because all along the way, there's multiple different avenues where you could find something else that you're passionate about along the way, and you want to be able to follow that passion. I had no idea I wanted to be a pediatric heart surgeon up until my CT fellowship, actually. And so, you know, things will change in terms of what you're most interested in, what you see, what you like. Just never be afraid to keep all the doors open and consider, anything whenever you're in your training as a med student and a resident all along the way. But what you'll find is that there's things that you gravitate to, right? You'll find that there's cases you're always looking at what's happening in that one room in the OR, right? And so definitely let yourself kind of continue following those passions. And if it's pediatric heart surgery, that's wonderful. There's going to be a shortage of pediatric heart surgeons. I know that's hard to believe because what you'll hear a lot of people talk about is a historic context from 5 years ago where there's 13 graduates every year and like 2 jobs in the United States. That's not the case anymore. The vast majority of pediatric heart surgeons are older, and you see that at the meetings if you come to them with me. A lot are older, and because of that, the way that we had a lot of people that didn't get jobs before, those people they're out of the mix now. They're in the adult pool in some fashion, and so now with the 2-year fellowship, which is 2 years of dedicated pediatric after 2 or 3 years of CT after general surgery, or an I6 followed by 2 years, right? Those are the two different pathways to get here. We only have 4 to 5 people graduating each year as pediatric heart surgeons. And there are going to be a lot of jobs. I can just tell you from my experiences here and what I see, there's a lot of jobs that are open. There's an adult congenital population that's growing because of all the kids like Truncus with severe regurg that we got through now in the last few years. But 10 years ago, they wouldn't have made it. Well, those kids are getting older and older, and they need reoperations, and they need operations as adults. So the population of congenital heart patients is growing because of the ones that have survived, which is awesome, but they do eventually need interventions, right? And so the need is increasing, the supply is decreasing. And so it is a great field to get into. And so hopefully people are kind of inspired by that rather than the historic context of, you can go through all these years and then you may not get a job. I don't think that's going to be the case soon. But you want to be the best you can be at every stage, right? That's the other thing I tell people. So whenever you're considering, I want to be a pediatric heart surgeon, don't choose your medical school or your general surgery residency or your I6 program based on a congenital fellowship at the end. Make sure that you get the best general surgery residency or I6 training that you can get, because eventually, once you get to your 2-year dedicated pediatric fellowship, that's when the pediatric training will occur. And if you show up to that not being able to operate because you got poor training leading up to it, you're going to have a really tough time. So just get the best training you can get at each sequence along the way, and then that'll make you the best ultimate surgeon.
Yes, sir. Thank you once again for a wonderful webinar, and thank you for that amazing advice.
Absolutely.
Yes, sir.
Perfect.
Webinar is going to be recorded. If anyone joined late, it will be uploaded to YouTube, hopefully later on today. Thank you again, Dr. Overbey.
Of course, and my name is there on the slide in front of you. It's douglas.overbey@duke.edu if anybody has questions they want to email me for, okay?
Have a good night, everyone.